Greetings, my dear friends and listeners. Welcome to Pulmonology Read Aloud. Today, I'm here with a slightly different format. This is a presentation that I had recently delivered on rheumatoid arthritis ILD's recent updates. It was appreciated by the audience, and I feel that at large, it is a topic that really mentions a specific discussion apart from SARD ILDs alone. So I am repeating this presentation for you all and recording it so that it could benefit all of you. So let's get started. Now, interstitial lung disease in rheumatoid arthritis is a huge challenge for clinicians, and it is associated with a lot of morbidity and mortality. So, when it comes to rheumatoid arthritis, which is one of the most commonly seen autoimmune diseases in our clinical practice, we have to have a clear cut idea of how to manage the lung involvement in this disease. Now, it is said that almost 7.7% patients of rheumatoid arthritis will have lung involvement in their lifetime. So, the lifetime risk is that much. And other than that, as we know, it will involve mostly the joints as polyarthritis and will lead to synovial tissue involvement with joint erosions and swelling. Now, a lot of times, lung involvement precedes the articular involvement. In fact, up to 14% patients may have lung involvement up to 5 years before the joint involvement or joint pain starts. So, it's not that you would always get a classical history of joint pains before you come and establish the diagnosis. And a lot of times it would be ILD, which would be diagnosed first, and then the joint pains. So, in the lung, rheumatoid arthritis can affect the parenchyma, the airway, and the pleura. Parenchymal lung disease is usually in the form of UIP pattern, most commonly up to 66%, NSIP pattern up to 50 to 57% of the patients who develop ILD, and the less common is organizing pneumonia, also lip and dip, which can be seen in up to 11%. So almost 66% patients of ILD in RA will have UIP, and that is, we know, a very poorer performance and prognosis as compared to other ILDs. So here the relevance or the prevalence of RA-related ILD is that up to 60% patients can develop ILD in the lungs if they have rheumatoid arthritis. We definitely have to keep in mind that when we talk about rheumatoid arthritis, infections are one of the most common cause of presentation for respiratory symptoms. So infections must be ruled out first, because a lot of these patients are immunosuppressed and can come with infection. So we don't want to overdiagnose and falsely diagnose them to have ILD. Another aspect that is important is drug-induced hypersensitivity, because methotrexate, which is a very commonly used drug for rheumatoid arthritis, we know can cause methotrexate-induced pneumonitis or hypersensitivity kind of reaction, which usually begins classically with a history after starting methotrexate. However, that's also one very important differential. So once we've differentiated, and if we look at just ILD, then ILD can occur in even up to 50 to 60% patients and will be a major cause of morbidity, mortality, shortened survival in patients with RA compared to those who do not have ILD. What are the risk factors to say that this patient can have lung involvement? Now, all patients with rheumatoid arthritis will not have lung involvement at presentation, or some may not even have that during their lifetime. But as I said, a lot of patients will develop. So, now those factors which predispose in developing lung involvement usually are advancing age. And not only do they preclude lung involvement, they also tell us that this patient will have a poorer prognosis. Other important factors are the genetics of a patient. So it's said in the patient with the right genetic profile, and factors such as higher age, smoking, or poorly controlled joint disease, they will have more risk of developing RA-ILD. Another thing is circulating markers. It's seen the higher the circulating markers, the more risk of lung involvement, and the higher duration since the patient developed rheumatoid arthritis, the risk of developing lung involvement will be more. So, a patient who's been having rheumatoid arthritis for past 20 years walks into your OPD, please do screen the lung compared to a patient who was just diagnosed last year with joint disease and does not have any lung related symptom. Now, if we talk about treatment of rheumatoid arthritis in general, we know that disease modifying anti-rheumatic drugs or DMARDs are the backbone of treatment according to the American College of Rheumatology. Now, these are divided into synthetic DMARDs, targeted synthetic DMARDs, and biologic DMARDs. Now, most of these target the joint and they have been proven beneficial. However, most of these are not the recommended treatment for managing the interstitial lung disease and rheumatoid arthritis, and that is something that must go as a take home after listening to this talk. What is most important in RA-ILD is immunosuppression. However, again, immunosuppression's use has been primarily extrapolated from RCTs done in mainly patients with systemic sclerosis related ILD, and with rheumatoid arthritis, the evidence that we have of immunosuppression also is mostly retrospective and observational in nature. However, again, it's important to know that if we are only depending on these drugs, then lung disease may not be managed appropriately. So, treatment recommendations have come up which talk about how to manage RA-ILD also, and that is what I'll be discussing in the next few minutes. Now, if we look at the ACR recommendations for a DMARD naive patient with low disease activity of the joints, they usually start with HCQS, sulfasalazine, methotrexate, and leflunomide in that order. The ACR also mentions that if a patient has clinically diagnosed or mild or stable lung disease and you are to manage the joint problems in this patient, then amongst the DMARDs available, we should preferably give methotrexate because the other synthetic DMARDs may actually cause more harm than benefit. So with that, mostly patients who are with pulmonary disease are kept on methotrexate for the joint problems. But what do we do for the patient's lung problem? To answer that, it's important to understand the pathogenesis of rheumatoid arthritis. Now, when we talk about pathogenesis of rheumatoid arthritis for lung disease, then it is an interplay between lot of risk factors, which includes, as I said, the genetics of the patient, the smoking history of the patient, the age of the patient, and genetic factors like HLA-DRB1 epitope, which predispose one to develop lung disease. So in the lung, lot of environmental exposures, they cause airway and epithelial cell damage. This leads to increased citrullination of proteins, which in an individual who is genetically predisposed triggers an inflammatory process which is characterized by activation of cytokines, chemokines, growth factors, TNF, vascular endothelial growth factor, PDGF, and interleukins. All of this contributes to both proliferation and differentiation of fibroblasts. There's an increased synthesis and deposition of extracellular matrix and metalloproteinases, and all of this will result in development of ILD and pulmonary fibrosis. In the synovial lining also, these fibroblasts can cause a similar role in pathogenesis of joint manifestations of rheumatoid arthritis. So what are the therapeutic targets when we talk about the lung? It would include smoking cessation. It would include drugs that bind to the CD20 receptor and cause B cell depletion, for example, rituximab. It would include antiproliferative or cytotoxic agents like cyclophosphamide and MMF. It would include TNF alpha inhibitors like adalimumab, etanercept, infliximab. It could include pro-inflammatory IL-6 inhibitors like tocilizumab and should include antifibrotics like nintedanib and pirfenidone. What is not included in this figure is the broad coverage of corticosteroids, which give an anti-inflammatory response by inhibiting prostaglandins and leukotriene synthesis and reducing the circulating monocytes. And steroids also inhibit the release of certain enzymes like collagenase and lysosomal enzymes and cause reduced inflammation. What about non-biologic or the conventional DMARDs like methotrexate? So the mechanism here is not very clearly known, but then it involves adenosine signaling, it increases adenosine levels and leads to an anti-inflammatory state. So with that, we see that there are a lot of targets that one can look at when we talk about lung disease. So, how do we approach a patient of rheumatoid arthritis with lung involvement? So, if we're looking at a patient who has an HRCT evidence of interstitial abnormalities, and we know that serologies are favorable for rheumatoid arthritis, the rheumatologist is confident that this is RA, and we are seeing interstitial lung abnormalities. It's good to have a multidisciplinary discussion with the radiologist and the rheumatologist, try to establish the pattern of disease and try to exclude not only infections, include hypersensitivity reactions, and also alternate diagnosis. And that we have to do before we label him as RA-ILD, because infections, as I said, are also one of the most commonly presenting confounders. So here the approach really has to be a good multidisciplinary discussion and ruling out the other causes. Now, latest in August 2024, this year, there have been two main publications which have looked at autoimmune rheumatic diseases, of which RA-ILD was a part. Now, these two are first a joint guideline by the ACCP and ACR, which I have discussed in one of my previous videos. In case you haven't seen that video, I will be attaching a hyperlink for that. Please go ahead and see that video. And the other is this guideline on screening and monitoring of ILD, which I'll be briefly discussing. So this talk is mainly targeting on RA-ILD. So some of it may overlap with the SARD-ILD video, but then I will be speaking specific for RA-ILD as well here. So the screening recommendations as per the ACR, ACCP for all SARD-ILDs have been PFTs, including Spiro, lung volume, DLCO, and HRCT, preferably both than one over the other. And as I have already mentioned in my previous videos, the screening is recommended against doing just a chest radiograph or just a 6-minute walk test or ambulatory desaturation testing to screen, because we might miss a lot of cases if we use only these modalities for screening. We have to use the PFTs and we have to use the CT in addition with definitely clinical worsening. They also recommend that we should not be using bronchoscopy as an aid of screening for RA-ILD. It should be reserved for infections. It should be reserved for other diagnoses like sarcoid or an alveolar hemorrhage kind of condition in a mixed presentation or other issues. And also, surgical lung biopsy must not be used in any of the rheumatic ILDs for screening. When we would use that would be when we are, suspecting a malignancy or something else where we need a biopsy tissue. So for both monitoring and screening, it's important to be more targeted in what we want to achieve. What is the relevance of biomarkers? And in RA-ILD, as you all know, we commonly do RF factor for RA and anti-CCP antibodies. So both RF factor and anti-CCP are found to be higher in individuals who have RA-ILD versus individuals who have only RA. But is there a cutoff? Is there a specific value that one can say is showing that this patient may have RA-ILD? Answer is no. But yes, the higher the values, advancing age, longer duration of symptoms, already on medications, not improving symptoms, please do suspect that there could be a lung involvement. Now, there have been attempts recently to compile all the factors that are there to have scoring systems so that we are able to quickly clinically assess whether a patient is at risk of ILD. And one such very very clear and very simple four-factor risk score has been published in 2023, which talks about age of onset, smoking, RF titer, and CCP titer. They say that if the value is more than 5, then there's almost an 86% sensitivity. But the specificity is low, it's only 68%. So this definitely needs more validation. More scores are coming up, and probably that is something in the future that one will be getting simpler tools. Coming to treatment of RA-ILD, as I said, I've covered it in my SARD-ILD lecture for all of the SARD-ILDs, but today I'm talking on only rheumatoid arthritis. So here, again, the first line ILD therapy, management, and additionally glucocorticoids is the mainstay of treatment. Remember, glucocorticoids have to be given short term and not long term. They are only a bridge therapy till your immunosuppression starts working or is instituted. What are the most commonly prescribed immunosuppressants in RA-ILD? Suggested are mycophenolate, azathioprine, and rituximab, with cyclophosphamide as an additional option when these three are not feasible, not available, or there is a life-threatening issue. For oral glucocorticoids, I've already mentioned in my previous talk, but we need to give shorter treatment, preferably oral, avoid IV unless severe. Um, there is some consensus whether we should give it when there's advanced fibrotic disease, but definitely where is it mentioned that it should not be given. So you may have to give it as a bridge therapy here again at the lowest effective dose, and specifically when you see patterns like OP. So based on that, oral glucocorticoids can short term be added. But what is the first line for RA-ILD? MMF, azathioprine, or rituximab with additional cyclophosphamide if needed. Which one of these three is better? There have been a lot of trials comparing head to head each of these drugs. And if you look at this study published in Chest in 2023, it's a beautiful study which tells us that the PFT trajectory of decline will be more severe in case a patient is not given immunosuppression versus immunosuppression. So whether a patient has UIP or non-UIP, and has rheumatoid arthritis, data retrospective analysis in this meta-analysis has shown that the decline in efficacy and DLCO, which will be much less over the years once the drugs, the immunosuppressants are instituted. So this is something which is very, very important. Does it vary if you give azathioprine or mycophenolate or rituximab? The answer is no. There's no clinically significant difference whether you give either of the drugs. But yes, it will matter based on what patient profile you're seeing and what patient's own preferences are. Does the patient prefer oral? Does the patient prefer coming in for an infusion? And what is the side effect profile we're dealing with, and what are the other comorbidities your patient has. But you can safely give either of these drugs with the confidence that they'll be efficacious. What does affect it is tolerability and side effects. Data mostly has shown azathioprine to be least tolerable, followed by MMF and rituximab. Again, it varies from patient population to patient population. In my own setting, again, I was mostly looking out for more side effects with MMF, but I've seen that patients are tolerating it well. So again, this is something that has to be looked at individually, but that is what will guide what treatment he's on. So for the first line treatment, amongst all the options, another factor that really determines what you give is the kind of indication. When you're dealing with inflammatory arthritis with ILD, rituximab would be the preferred choice because it works for arthritis. MMF is less effective in arthritis. So either we would be giving it to a patient who does not have arthritis manifestations, or if he does, he may have to be on a DMARD such as methotrexate also. Azathioprine has some effect on arthritis, and cyclophosphamide, as I said, will be given when adverse effects can be accepted. So what is not recommended as a first line? The guideline statement has for all SARD ILD said that leflunomide, methotrexate, TNF alpha inhibitors and abatacept should not be given as a first line initial treatment for SAD ILD. Let's look at the evidence for rheumatoid arthritis in this regard. So, talking about methotrexate first. Now, we know that DMARDs are so important when we manage joint disease, and methotrexate is most commonly used. What happens when you use methotrexate in RA-ILD? Now, it's clearly said that methotrexate can be continued in patients with ILD who are receiving it for extrapulmonary manifestation. But obviously, you would stop it when there's a concern for methotrexate pneumonitis. And they also say that some panelists would stop it if ILD developed while on methotrexate. Now, why that happens is because we know that nearly all anti-rheumatic drugs can worsen ILD, and methotrexate is particularly notorious for, inducing ILD or fibrosis in worsening ILD. However, recently there has been more compelling data from large retrospective studies with systematic evaluation of this HRCT and methotrexate exposure. One of these studies has looked at 410 patients with rheumatoid arthritis ILD and 673 patients with just rheumatoid arthritis and no ILD. This study, published by Juge et al., did not see any associated increased risk of rheumatoid arthritis ILD in patients with rheumatoid arthritis. In fact, they said that those patients who were on methotrexate, their ILD was detected later. So, in other words, a lot of studies are saying that patients who were taking methotrexate for their RA were less likely to have ILD than those who were not taking methotrexate. And a delay in HRCT detection of ILD was by almost 3.6 years in patients exposed to methotrexate compared to never exposed patients. Now, does this prove causality? It doesn't prove that this is a cause and effect relationship, but it does tell us that at least methotrexate exposure may be protective in RA-ILD rather than be the cause of RA-ILD. And also there are a lot of confounding factors. Maybe the physicians may have prescribed methotrexate less frequently to patients with respiratory symptoms, so we did not see those patients. But however, this has been seen in other studies also. So for now, there is no strong evidence or basis to say that methotrexate must be discontinued in the setting of fibrotic ILDs. Regarding leflunomide, it's a very commonly used anti-rheumatic drug, and there's a huge concern with it also because a lot of patients with the RA are nowadays on leflunomide. There are studies, especially the cohorts from Japan and Korea, that have mentioned that leflunomide can start ILD within 3 months of starting leflunomide. And the symptoms may start coming within a week or less. And this can be in the form of ground glassing or diffuse alveolar damage. If a patient already has ILD and is on leflunomide, this problem can be even more. So, we definitely can avoid this drug, and the guidelines mention that it should not be considered definitely as a first line. Coming to abatacept, it's a very promising anti-rheumatic drug. It's a fusion protein. The guideline has mentioned uncertain role, but there are studies that have looked at abatacept managing both joint as well as lung problems. So, if pulmonary function can be stabilized and joint inflammation can be stabilized with acceptable safety profile and ability to combine it with other immunosuppressants, that makes abatacept very promising, and hopefully we will have this as a future option also. Regarding TNF alpha inhibitors, the guidelines mentioned overall for SAD ILDs, we are looking at rheumatoid arthritis. There is a study from the British Society for Rheumatology Biologics Register in RA-ILD, and they did not find any increase in mortality with this medication. So again, a reserve drug probably for second line management, not as a first line. Now coming to antifibrotics, this is something which is an eye opener. The guideline mentioned that there is no consensus on antifibrotics in rheumatoid arthritis. They also say that for people with SAD ILDs in general, they recommend against starting pirfenidone, and that comes usually from the relief trial for pirfenidone in connective tissue disease ILDs or progressive ILDs, where it was stopped because of poor recruitment. Because the inbuilt study was successful and had a subgroup of patients with CTDs, they mentioned that nintedanib could be the first line when you want to start antifibrotics. But again, there's no clear consensus. So, what is the consensus? That is the recent trial. It's actually the first randomized controlled trial which was published to ascertain the safety and tolerability of pirfenidone in RA-ILD. One problem with this trial also has been its early termination, because again, this was also going on during the COVID pandemic in 2020. So they had to take in much more patients. They included 231 patients for assessment, but only 123 patients could be randomly assigned. And therefore, once the trial was stopped in March 2020, they could not recruit further, so they analyzed whatever they had. So the power of study is not perfect, it's not very strong, but the results are alarming. The difference in the proportion of patients who met the endpoint of reduction in decline in FVC from baseline of 10% or more, that reduction in pirfenidone group versus the placebo group is significant. And they found that compared with placebo, these patients had slower rate of lung function, and the estimated difference is almost 80 ml plus minus 30 ml per year, which is a huge difference. Now, this is something which is very promising. Were the side effects more in this group? No. But again, because the trial was concluded prematurely, we have to take this with a little bit of caution. However, the results are very encouraging. So, even in UIP and non-UIP pattern, when pirfenidone was added to the therapy in RA-ILD, the decline in FVC was much reduced, and hence in patients who are worsening on ILD with rheumatoid arthritis, pirfenidone will be our better choice with data specifically for rheumatoid arthritis as compared to nintedanib. What is the combination? So upfront, first line, do not start antifibrotics unless you've given the patient enough immunosuppression. If there is no progression, there is no need to start with antifibrotics sequentially or upfront. Monitor the patient, do a pulmonary function, do a CT scan, and as I have told in my previous video, in rheumatoid arthritis, the recommendation is every 3 months pulmonary function till patient is stabilized, HRCT when needed, and ambulatory desaturation testing again every 3 to 12 months. What is progression defined as? No consensus. Most research looks at the inbuilt criteria of 10% decline in FVC or 5 to 10% with symptoms, with worsening, or with UIP. So, if we take those criteria and the patient continues to progress, what is the second line therapy? We need to increase immunosuppression. So, either you add immunosuppression or you switch what you gave earlier. Should you give this patient steroids for long term? This is not improving. No, we should avoid long term steroids more than 3 to 6 months. So, once a patient is already progressing, it's time to give dual, immunosuppression rather than continuing steroids. Also, a good time to refer the patient for lung transplant for evaluation. So, what are the options here for RA-ILD? For RA-ILD, the options are mycophenolate if already not given, rituximab, antifibrotics, nintedanib, pirfenidone, tocilizumab, and cyclophosphamide. And as I said, from the TRAIL 1 study, the first RCT published, pirfenidone is recommended in RA-ILD conditionally, while in all others it is not. So pirfenidone can be even considered in patients with UIP pattern. That's important. Tocilizumab is also recommended in RA-ILD and in MCTD with SSC phenotype. It works more for patients with more inflammation and early progressive disease. If the patient rapidly worsens from breathing in room air to now being ventilated, definitely the treatment has to be very, very aggressive. And if you look at RA-ILD, in addition with IV glucocorticoids pulse, We can start upfront double or triple therapy, pulse IV methylpred followed by high dose oral prednisolone. We have to start other immunosuppressants. Choose cyclophosphamide IV over oral. Choose cyclophosphamide over MMF and azathioprine. And there is no role of giving methotrexate, lefno, azathioprine, and others. We can give IVIG conditionally according to guidelines in such a situation. We can give JAK inhibitors, calcineurin inhibitors if needed, if we have already exhausted whatever we have. But lung transplant referral is something that must be happening here. Other interventions in RA-ILD is just like other SARD-ILDs, pulmonary rehab, vaccination, smoking cessation. We do not have to forget that. And since lung transplantation, the recommendation is more blanket, medically manage first, consider early referral, but don't wait for medical management. And this paper for criteria of referral and listing by Dr. Ganesh Raghu talks about ILDs in general. And for RA-ILD, one does understand that the specific risks could be pulmonary hypertension and right ventricular failure, occurrence of pneumothorax, UIP pattern. In such a case, you may want to quickly refer this patient because options for medical therapy may be swayed by patient's status, patient's candidacy for lung transplant. One very soft indicator is requirement of high flow oxygen that warrants transfer to a transplantation center. And with that, the approach essentially should be that when you are having an RA-ILD, you would want to screen the patient based on his risk, based on his age, based on other factors. No signs, just wait and watch and follow up. Signs present, reevaluate, confirm diagnosis, and if he's subclinical, stable, just do the maintenance treatment. Say just give DMARDs if no chest complaints. Not stable, CT evidence of ILD, manage accordingly. Look for responders, non-responders, progressors, or patients who stabilize and consider evaluation for lung transplant. So, treatment should be initiated in patients who are symptomatic, progressing, high risk. MMF, azathioprine, and rituximab are important therapies. Corticosteroids should be only a bridge. Abatacept may be a potential future. Even if you have UIP pattern, based on the pattern, you should not stop giving immunosuppressants. It's only the extent of disease more. We still don't know the right timing to initiate ILD treatment based on evidence. We still cannot predict who will be stable, who will progress, and maybe it's time we have to look at personalized approach. With that, thank you from Pulmonology Read Aloud. I hope you liked this talk. It was a bit different from my usual read alouds. The references are there at the end of each slide. If you have doubts for any other reference, please reach out through the comment section and see you again with another topic. Bye and happy reading.